In clinical urology, overlapping symptoms frequently obscure underlying pathology that threatens organ viability, demanding immediate and precise triage. Achieving diagnostic accuracy requires discarding vague historical terminology in favor of rigid, evidence-based physiological categorization. This analysis relies on a comparative framework, differentiating specific pain patterns, classifying lower urinary tract dysfunction, and outlining protocolized responses to acute emergencies. This matrix will map distinct clinical dichotomies side by side, separating generalized complaints from true anatomical defects. Applying these comparative frameworks allows the clinician to move from a vague patient complaint toward a high-yield diagnostic modality. We begin by breaking down our first clinical dichotomy, distinguishing true renal pain from the often misnamed condition known as renal colic. True renal pain is a constant ache caused by physical distension of the renal capsule. Contrast this with ureteric colic. An obstructing calculus triggers rhythmic waves of proximal spasm. This lateralized pain radiates to the groin, but never down the back of the leg. A patient can experience both pain types simultaneously. If distal ureteric obstruction causes enough fluid backup, it eventually distends the proximal renal capsule. Once the pain pattern is identified, we turn to baseline imaging to visualize the obstruction. This plain radiograph demonstrates typical urinary tract calculi. Two distinct radiopaque stones are visible in the right renal area, against the spine. Precisely identifying the radiation and nature of the pain dictates whether you direct your investigation toward the kidney capsule or down the ureteric pathway. Moving to the external genitalia, sudden, severe scrotal pain in a young male is testicular torsion until proven otherwise. Physical examination of the asymptomatic testicle may reveal a horizontal or Clapper-Bell lie, which increases clinical suspicion for a torsion event. Suspected torsion requires immediate surgical exploration and bilateral fixation. The time to ischemia dictates organ survival, leaving no room for delay. The primary differential diagnosis is acute epididymitis. Often linked to infections like chlamydia in sexually active males, it presents with similar pain and swelling. Doppler ultrasound serves as the definitive diagnostic tiebreaker. In torsion, the ultrasound shows decreased or absent blood flow to the testis. In epididymitis, it shows the opposite, highly increased inflammatory blood flow directed specifically into the epididymis. Relying on objective perfusion data, rather than the subjective severity of the pain, prevents the catastrophic misdiagnosis of a dying organ. When evaluating urinary function, the term prostatism is clinically obsolete. It incorrectly attributes all voiding issues to benign prostatic hyperplasia. This pressure-volume curve outlines the modern framework of lower urinary tract symptoms, categorizing them into three phases. Storage lets indicate the bladder is failing as a low-pressure reservoir. Voiding lets point to an outflow problem, typical of bladder outlet obstruction. Post-micturition lets manifest as the sensation of incomplete emptying and involuntary post-micturition dribble. This cystoscopy image shows the consequences of chronic bladder outlet obstruction. Dark saccules and heavy trabeculation indicate severe hypertrophy and damage to the bladder wall. Because storage neuropathies and anatomical obstructions frequently coexist, urodynamic pressure flow studies remain the gold standard for evaluating complex, overlapping symptoms. Discarding the umbrella term of prostatism in favor of phase-specific categorization is essential to ensure clinicians do not miss these parallel pathologies. Painless haematuria is a cardinal urological red flag. It demands immediate investigation, regardless of whether the patient is on anticoagulant therapy. We rapidly generate differential diagnoses using the TIN framework, standing for trauma, infection, and neoplasm, located anywhere along the urinary tract. This clinical decision tree maps the ontological risk stratification based on visibility. Visible hematuria carries a cancer detection rate of approximately 20%. In cases of non-visible hematuria, that risk drops significantly to below 5%. Initial hematuria indicates urethral pathology. Blood throughout suggests the bladder, and terminal hematuria isolates the prostate. The mandatory imaging cascade for painless hematuria starts with a baseline ultrasound of the kidneys, ureters, and bladder, followed by non-contrast computed tomography if required. If imaging is negative, cystoscopy is mandatory. It allows direct visualization of flat malignancies, like the abnormal vascular networks of carcinoma in situ seen here. Treating hematuria through strict protocolized algorithms rather than assumption is the only proven method to catch occult urological malignancies before they progress. The final step of urological triage requires selecting the precise, advanced diagnostic modality to confirm our clinical suspicion. For suspected urinary tract calculi, the non-contrast CT scan is the absolute gold standard due to its unmatched speed and high sensitivity. When evaluating renal cysts on CT imaging, we strictly apply the Bosniak classification system to gauge their complexity. This scan shows a large heterogeneous left renal mass. Bosniak type 3 or 4 structures carry high malignancy risk, demanding biopsy or excision. When evaluating for prostate cancer, multiparametric MRI utilizes the PRAD scoring system to assess malignancy risk and guide tissue sampling. This imaging enables targeted transperineal biopsies, which avoid rectum and therefore carry a significantly lower sepsis risk than traditional transrectal approaches. We must also account for laboratory factors. Prostate-specific antigen levels can be spiked by a simple urinary tract infection or artificially suppressed by 5-alpha reductase inhibitors. For evaluating testicular cancer, the reliable serum tumor markers required are alpha-fetoprotein, beta-HCG, and lactate dehydrogenase. Pairing the correct clinical pattern with its exact advanced diagnostic counterpart is the hallmark of clinical urology. Our comparative framework is now fully populated with the physiological realities of modern urology. We can distinguish constant capsular renal pain from the radiating spasms of ureteric colic to precisely pinpoint urinary obstruction. Phase-specific categorization ensures that low-pressure storage neuropathies are never confused with mechanical outlet obstructions. And aggressive risk stratification, utilizing the TIN framework for hematuria and Doppler ultrasound for the acute scrotum, filters out clinical noise in emergency settings. Rigorous physiological categorization dictates the precise deployment of advanced modalities, ensuring rapid, accurate intervention in a field where time dictates organ survival.